Hello, my name is Kathia Skinner, and my quality improvement project was titled Improving Patient-Centered Care in a Mild Dysplastic Syndrome Clinic Using Patient Engagement Tools. It was a very challenging project to implement. In a 4 Rapid Plan Do Study Act, also known as PDSA cycles, within an 8-week time period. In fact, it was one of the hardest things I've ever done in my life. I chose difficult core interventions because it was what I felt the change was needed in our clinic. I told myself that despite it being difficult to accomplish, it would work out because the evidence was there to support the initiative. It was a nationally recognized problem, and the solutions were well defined. Well, I was wrong. I quickly realized as the first PDSA cycle launched that it was no longer our project, but rather my project. It was something only tolerated until the 8 weeks were over. I've made some mistakes by making my criteria too stringent. And when the data was insufficient, I jumped to spreading rather than continuing to do small tests of change. This further limited my data. Yet, of the data that I did collect, it was powerful and meaningful. Disseminating the findings were not as difficult as it was displaying and articulating it, particularly within a 15 to 20 minute time frame. There was so much I wanted to say. However, I needed to learn how to address all the matters most important to the interdisciplinary team without placing blame to one particular group of people. With the help of Dr. Giles, I learned which charts were just pretty and which really said something meaningful. I learned how to apply the data that helped the reader to follow along. Something as simple as ordering the symptoms from highest to lowest in a table allowed the reader to focus their attention to the data that was the most meaningful. It felt as though I was learning a new language that I needed to simplify for others to understand. At the conclusion of my presentation, all of the key stakeholders, aside from the attendings, showered praise for the project. They verbalized the importance of the findings and encouraged further conversations for change. The attendings did not show respect for the project, and things went right back to normal once the 8 weeks were over. We stopped screening for distress and depression, and we stopped tracking the nurse assignment scores. I was incredibly proud of the hard work that myself and my colleagues had put into the project, and felt increasingly conflicted by the lack of right care we were providing for patients truly suffering from a grave disease, when my project clearly showed that with distress screening and the utilization of case management logs, we're able to drive right care management scores significantly up. I began to see the team I adored differently. I no longer saw the lead physician as my mentor because he saw my project as a joke. In fact, he asked me if I really thought the way we managed patients changed with my project. It opened my eyes in ways I could not have imagined. I noticed how often patients' distress, emotional distress particularly, and wishes were ignored because they were not thinking clearly. I saw how often patients were convinced to start treatment when there were no effective therapies left. And I saw how many patients verbalized depression because they could follow up with their primary care provider. I learned that the issues of my quality improvement project were much larger than our clinic. It was a systemic issue, particularly in areas focused on curative care, areas that did not have models which combined curative and palliative care. On a personal and professional level, I developed because I realized that doing something right may require you to be comfortable standing alone, using the data and evidence to talk for you. I learned that buy-in may never occur prior to the start of something, but after you took a leap of faith to work alone, and after you have gathered enough evidence to speak for your cause. This new knowledge was very humbling. Over this DMP project, I developed many skills that built my confidence in providing patient-centered care and quality improvement. Most importantly, I saw how important quality improvement was. As APRNs, we are the pilots of change because we use our nursing passion for holistic healing and combine it with our medical knowledge to drive quality care. Frontier Nursing University energized me to see myself entirely, my strengths, weaknesses, and passions. I know that it is time for me to move on to a different institution because it became evident that working for an institution that is not willing to grow cannot be a foundation of your personal growth. No matter how much you water your soil, you cannot bloom in an environment that is not compatible. In 5 years, God willing, I envision myself teaching at the university level and working in a family practice. I also want to get involved in policy advocacy. This course and program as a whole has changed the way I view my role as a provider and the responsibility I have to be a catalyst for change, and for that, I am forever grateful. Thank you.